Good morning, this is Carlos. I'm just saying hello to everybody. Can people hear me?
Yes, I can hear you, Carlos. This is Anton from Barbados.
Hello, Anton.
Hi, Anton. Hi, Carlos. Maivy from PAHO, Washington.
Hello,
Hi.
Maivy. How are you?
Hi, morning, Carlos. Nikia Forbes in the Bahamas.
Oh, hello, Nikia. Pleased to meet
and
you
this
too.
is Cedric Martin from Kingston.
Okay, your name is Cedric Martin, okay? I thought it might be Martin or Martin, depending on
Martin.
English or French. Okay, great. Thank you. So we'll be here, and only Maeve has slides, I assume. So we're fine, and we'll just have her present. I will introduce people first. Or I don't know, maybe I can introduce, since you guys are so many, I may introduce people one by one so that people don't get lost with too many introductions. So I'll do that. And I'll also refer to the questions planned by Maeve in the organization of the session. So we'll talk in a couple of minutes. Okay, thank you.
Thank you.
Okay, good morning, everybody. This is Carlos Cáceres from NEMUS. I will coordinate this session, which covers a very interesting topic. On December 1st, 2017, 3 months ago, PAHO, in collaboration with UNAIDS, launched an analysis of the situation of policy adoption and implementation of combined HIV prevention in Latin America and the Caribbean. This was an effort to monitor progress towards HIV prevention goals as part of the commitment of the governments of Latin America and the Caribbean to end the AIDS epidemic by the year 2030, and also to analyze the achievements and challenges to prevent HIV infection in the health sector, from the health sector in the region, focusing on key populations particularly, because the epidemic is concentrated in those key populations in most of the region. The report was based on a compilation of published information and collection of additional data through questionnaires, as well as virtual and face-to-face consultations with countries and civil society organizations. So this report was particularly relevant and timely because the number of new HIV cases in Latin America and the Caribbean is the same as in 2010. That is approximately 120,000 new infections occurring each year. And it's estimated that the number of new infections in adult men has in fact increased between 2010 and 2016. So today we're presenting, in fact, this document called HIV Prevention in the Spotlight. So we are talking about assessing progress in the implementation of combination HIV prevention in Latin America and the Caribbean from the health sector perspective. We already had a session focused on Spanish and Portuguese speaking countries last week. So this session is going to be focused on the Caribbean. Today, the presentation of the document will be made by Dr. Maeve de Mello, and we will have comments from 3 different perspectives. Now, those will come from a focus on combination prevention in practice, that is country perspectives, to be made by Dr. Anton Best from Barbados and Dr. Nikia Forbes from Bahamas. Then a presentation on structural barriers, stigma and discrimination, made by Cedrian Martin from UNAIDS, and finally, civil society perspective, essentially engagement, social contracting, and sustainability, made by Mrs. Rachel Erstel from Linkages Suriname. So I will start by presenting Maeve. Maeve de Mello, Dr. de Mello from PAHO, holds a bachelor's degree in biological sciences, a postgraduate degree in human sexuality from the State University in Campinas, Brazil, and a PhD in community ecology from the University of Sunderland in the UK. At present, her field of expertise is concentrated on public health policy development and implementation, surveillance, and monitoring and evaluation of HIV and STI prevention interventions, with particular focus on key populations in Latin America and the Caribbean. In 2015, she started working as a specialist in PAHO headquarters to support the validation process of the elimination of mother-to-child transmission of HIV. And since 2017, she's the regional advisor on HIV and STI prevention. So please, Dr. de Mello, welcome, and the floor is yours.
Good morning, everybody, and thank you, Carlos, for this very nice and thorough introduction, and for sponsoring the NEMUS webinar and inviting PAHO to present this publication that was prepared in partnership with UNAIDS. So why this report? As we all know, countries have committed at both global and regional levels to end AIDS as a public health problem by 2030. In addition, countries in our region have committed to specific HIV prevention targets, which were framed within the combination prevention approach during the second Latin American and Caribbean Forum that happened in Brazil in 2015.
Excuse me, Maeve, I think your presentation, are you showing your presentation? You have to share your screen. Compartir la pantalla.
I thought I was.
No problem. So, Miguel, hemos hecho presentadora, ¿no es cierto? Yes. Okay, great. Now we can see it. Yeah,
all right,
excellent.
wonderful, and I'm really sorry about that. So,
Okay, thanks.
okay, so one of the regional targets, it was for the reduction of new HIV infections by 75%, very optimistic, from by 2020, taking 2010 as baseline. And where are we with this particular target in our region? So as Carlos has mentioned, new infections are pretty stagnant since 2010 and 120 per 1,000 per year. But it's important to notice that while Latin America, you have this pretty flat line for males and females, adult males and females. In the Caribbean, you actually have a decrease in the same proportion as you have among females as you have an increase among males at an order of 8%, and they cancel itself out. And you know, if you just look at the combined information, you're going to have a flat line. And similarly, if we are going to look for per country, you're going to have different scenarios as well. But overall, countries are not look like any of the countries in our region are going to reach the agreed target by 2020. So something has to be done about that. And we all know that the distribution of new infections in our region is very much concentrated in key populations, and which are disproportionately affected by the epidemic in relation to their population size. So in this sense, this publication has focused on the three main key populations, the three most affected ones: gay men and other men who have sex with men, transgender women and female sex workers, and on the HIV prevention from the perspective of the health sector. So the HIV prevention in the spotlight was a result of a multi-sectoral consultation process involving national AIDS programs, international cooperation agencies, civil society representatives, and people living with HIV in more than 12 countries. Data analyzed from structured questionnaires received from another 28 countries in the region in 2017, as well as data reported at the GAM platform by countries, and that would be the data from 2016. Within the conceptual framework of HIV combination prevention, so WHO has recommended a set of essential interventions for the health sector with focus on key populations. In this sense, analyzing then the information we had for the region, we have only Brazil in Latin America and the Bahamas and Barbados in the Caribbean currently offering the full package of high-impact biomedical interventions recommended by WHO for key populations. And today in this webinar, we're going to hear the experiences of both Barbados and Bahamas. So analyzing the adoption of this health sector interventions as country policies, we found considerable gaps in the region. For example, 3 countries which are exactly the same currently offering PrEP as part of their public policy, which corresponds at about 6% of all countries in LAC, in Latin America and the Caribbean. Around 40% have the post-exposure prophylaxis, PEP, as national policy that includes the accidental exposure during consensual sex. And around 45% have adopted WHO recommended treat-all approach. In addition, two important missed opportunities in service provision and for integration of services. Particularly, countries' policies do not always address transgender women as one of their key populations in their policies. Even if you only look, for example, at the number of countries that offer free and distribution of condom and lubricants. So if you look at the column for transgender women, the figures are generally lower. So analyzing each of the HIV prevention interventions separately, and starting by the provision of HIV testing services, the results have shown a series of missed opportunities to diagnose HIV and enroll persons living with HIV into care. Although there was a slight improvement in the percentage of people who know their HIV status from the year before, 15 to 16, in both Latin America and the Caribbean, still 1 in every 3 diagnoses are occurring late. The regional average for the first CD4 count has not shown changes in the past 4 years, and it's higher in men when compared to that of women. So late diagnosis at about a third of men are diagnosed with CD4. The basal CD4 is smaller than 200 cells as compared to 20% of women. There are also many lost opportunities to expand diagnostic coverage. HIV self-testing, for example, it's only available currently in 5 of the countries. And in no countries, HIV self-testing was offered free of charge by last year. And WHO pre-qualified dual rapid test in the same platform where you have HIV and syphilis is really seldom used in the region. There is a strong need to review and update diagnostic algorithms based on the latest WHO recommendations in order to optimize those optimize diagnosis and reduce waiting times for confirmation of positive result. We need to review legal barriers for testing. So we have about over half, at approximately 60% of the countries, having as age limit for HIV testing at 18. Below that, young people cannot have an HIV test without parental consent. Only few countries allow testing by lay providers. Still, some require written informed consent for an HIV test with very lengthy and many times mandatory pre-test counseling instead of a brief information as recommended, and offering HIV testing at convenient times, convenient locations for key populations is still not widespread. So, although we know for many years the association between STIs and HIV infection, currently recognized as syndemic or syndemic epidemics, or in 35% of the countries, syphilis testing is not offered at the same time as HIV testing for key populations. Rapid testing is only used for 42% of the countries for key populations, and only 2/3 perform some type of contact tracing and partner notification. The resistance of Neisseria gonorrhea to antibiotics has increased rapidly in recent years. There is, with a reduction of therapeutic options and reaching almost a status of superbug, as you can see in many recent publications. And in our region, 36% of the countries are performing surveillance of antimicrobial resistance of gonococcus. And we know that since 2009, there has been a sustained increase in the reported resistance to ciprofloxacin in the countries in the region, going from 35% in 2009 to 62% of isolates in 15. And at the same time, almost, actually over 2/3 of countries still indicate ciprofloxacin or ceftriaxone alone as their first-line regimen. In addition, only 80% of the countries adopted WHO-recommended treatment schemes for gonorrhea in the absence of surveillance of resistance. Regarding condom use, all countries reported the provision of male condoms free of charge to all key populations, and almost all refer to distribution of lubricants. So some good news there. And at the same time, the purchase of condoms by countries are only 1/3 done based on national resources. Majority is still depending on donor funding. And based on reports from civil society, the number of condoms and lubricants is really not sufficient to the needs of the population. And many countries still do not use proven standard methodologies to estimate demand. So in our region, you have, when you look at condom in the last intercourse, the median percentage of condom use for men who have sex with men is estimated at approximately 63%, with quite a bit of variation among countries, and clearly far from the 90% as agreed target by the region. On the other hand, female sex workers have a very high median at 80% of the countries that we do have information on, and 88%, and transgender women at 80%. So, although WHO has issued a strong recommendation with high quality of evidence, PrEP is still very limited in the region, and as we said, only adopted currently by 3 countries. Other 5 countries do have PrEP for serodiscordant couples. 5 countries have PrEP being offered as an initiative of civil society, very localized, and some have it in private clinics. And 8 countries in the region are currently implementing pilots. One of the main barriers for the adoption of PrEP by countries is still the lack of knowledge among the various actors, including national programs and civil society representatives. So WHO, in support to rolling out of PrEP, has issued the PrEP toolkit, and we put the link there in case you haven't seen, and that's really guided to each of the key actors that you need to be all aligned in terms of really rolling out good PrEP. And for the countries in our region that can access PAHO Strategic Fund, it's possible to purchase generic PrEP that's pre-qualified by WHO for less than $8 per month per person. So one of the most important structural barriers for key populations to access HIV services, stigma and discrimination, was also highlighted in this report. But in this webinar, we will hear more from this from our colleague from UNAIDS, and who will advance this topic further. As a highlight, the legal framework over several countries in Latin America and the Caribbean continues to create barriers to access healthcare. So 10 countries still report existence of laws that criminalize HIV transmission, non-disclosure or exposure. 5 countries in the Caribbean report that MSM risk being prosecuted and incarcerated due to their sexual practice, and 1 country has actually reported incarceration. 6 countries in the Caribbean reported that sex work is considered a criminal act. And although no governments report transgender persons are criminalized, we know that hate crimes are disproportionately reported in LAC, increasing their vulnerability to an HIV infection even further. So the last session in the report, it focused on the financial sustainability of prevention interventions, and the conclusions are that in LAC, 82% of the countries depend on external funds for HIV prevention with key populations, and that all countries allocate insufficient financial resources at about 60% to civil society organizations to support addressing key populations. So, as conclusions, the report emphasizes that in the Latin American and the Caribbean region, the coverage of prevention interventions remain limited, which generates very good practices, but very little impact on the trajectory of the HIV epidemics. As we saw, it's stuck at 120,000 cases, new infections per year since 2010. The combination prevention approach, it's not fully understood, embraced, and incorporated by governments and by civil society. And not all WHO recommendations were implemented, such as PrEP, PEP for consensual sex, diagnosis and treatment of STIs, treatment independently of CD4 count to all, and other proven strategies to expand HIV testing coverage by making HIV diagnosis more accessible for key populations. In LAC, we know that there is a very strong commitment by governments and civil society to end AIDS. But we could see through this report that much remains to be done to improve quality of care and ensuring an enabling environment for key populations. We do hope that this publication will shed light on the gaps that needs urgent attention. And PAHO and WHO, together with UNAIDS, are here in the region to support countries to get there. So I would like to thank you all and get back to Carlos as the moderator for the panels to come. Thank you, Carlos.
Thank you very much, May, for an excellent presentation. So what we would do now, I think, is to get into the comment section. And we have 3 sections with 4 panelists. The first subsection within this comment section is about country perspectives, HIV prevention in practice. And here we have two people making comments, Dr. Anton Best from Barbados and Dr. Nikia Forbes from Bahamas. They will comment on the perspective of their respective country experiences. So, the general question is, what is your country doing to put in practice the HIV combination prevention approach? So let me just briefly introduce both of them. Dr. Anton Best is a senior medical officer of health with responsibility for HIV and STI programs in the Ministry of Health of Barbados from June 2007 to present. He's a physician and public health specialist with the Ministry of Health in Barbados since 1999. Just to save time, I mean, you can read the full introduction in the invitation. And Dr. Nikia Forbes, she's the director of the National HIV/AIDS and Infectious Disease Program at the Bahamas Ministry of Health. She's a consultant in infectious diseases at the Princess Margaret Hospital and Doctors Hospital, and an associate lecturer at the University of the West Indies School of Clinical Medicine. Okay, so please, Dr. Best and Dr. Forbes, the floor is yours.
Hi, Carlos. Thank you very much. It's really a pleasure to be here to hear this presentation. So thank you very much for the presentation that went before. I have a few comments that I would like to make. The first is about the nature of our HIV epidemic. Whenever I get the opportunity, I like to explain that the epidemic in Barbados is not a concentrated epidemic, but rather a mixed epidemic. And that has some implications, because what I find is a lot of persons want to focus on the concentrated part of the epidemic or the marginalized populations. But our situation, based on what we know, we believe that we have multiple epidemics. So at the same time, while we do have problems with key populations, we do have a problem in our general population as well. So, we have to take that into consideration. Specifically, we believe our HIV prevalence in the general population is about 1.5, 1.6%. A recently published study showed that it was 11.8% in MSM. We do not have any groups, any HIV prevalence data from other groups such as transgender persons or female sex workers, but we believe that the prevalence of HIV is possibly higher. Certainly those groups are vulnerable where HIV and STIs are concerned. So one of the things that I like to say is that we also have male-driven epidemics. When we look at our programmatic data, persons coming into clinic for the first time, almost exactly 1/3 are MSM, 1/3 are men who have sex with women, and then the other third are women. So there's a preponderance of males who are affected by HIV in terms of the number of new cases that are accessing care. And those are data that we have that are published in our surveillance reports. I like the fact that the HIV Prevention in the Spotlight presentation stated that we haven't paid sufficient attention to STIs, because that's one of the things that we have been trying to pay more and more attention to. We have sustained high rates of gonorrhea, as well as sustained high rates of chlamydia and relatively high rates of gonorrhea as well. And then over the last few years, we recognized that we had an increasing number of persons with syphilis. So a cause for concern in terms of sexual behavior, showing that our education programs and our behavioral change efforts are not as effective as we would have liked them to have been. So in terms of the programmatic response, we do have elements of HIV combination prevention strategy being utilized in Barbados. Specifically, we have HIV testing services. We screen for STIs as well as focus on management. We offer post-exposure prophylaxis. We only recently introduced pre-exposure prophylaxis within our program. In fact, it was officially approved earlier this month. Of course, we have our education programs as part of the broader health promotion agenda. And then there's treatment for all, something that we've been implementing since 2016. One of the deficits in terms of our combination prevention strategies, the whole issue of self-testing. Personally, I'm sitting on the fence where self-testing is concerned, but that's another discussion for another day. But then one of the bigger deficits is the structural barriers that must be addressed when you're talking about HIV combination prevention. The other thing that I should note is that while we're doing or implementing elements of combination prevention, we do not have a documented prevention strategy. So all that I've just described cannot be found in any one document saying that this is what we are implementing where combination prevention is concerned. These are our targets, etc. That's one of the things that we need to address. Starting from there, what I would recommend for Barbados is that we do need to focus on HIV combination prevention and develop such a strategy if we're going to achieve our goals by 2020 and by 2030. With the aid of PEPFAR, we have done some work regarding stigma-free healthcare services, and that's something that I certainly would like to recommend that we strengthen. There's always been a lot of talk about stigma and discrimination at the national level and changing policies and creating the enabling environments that we desire. But pragmatically, it's not politically feasible, or easily feasible, I should say, in the Caribbean. And I think a low-hanging fruit is to focus on where services are delivered and to implement strategies and policies at government clinics and even some private clinics in terms of having stigma-free services to increase access to or access by groups that are traditionally marginalized, and then even those that are not traditionally considered to be marginalized groups, such as migrants, which is a problem that we do face throughout the Caribbean. As I mentioned earlier, the presentation did highlight that there's insufficient attention paid to STIs. We have been working on that, and that's something that we certainly need to continue. And in terms of civil society involvement, we certainly have started under the Linkages Project, which is funded by PEPFAR under USAID. PEPFAR assistance to Barbados is coming to an end in September. We are looking for ways to sustain a lot of the meaningful and impactful work that we started under PEPFAR, and certainly the involvement of civil society organizations in particular to help us provide services to marginalized groups, I think is one of the more important strategies that we need to implement. That's it for now.
Great, thank you very much. Please, Dr. Forbes.
Thank you very much for your kind introduction. I really enjoyed the presentation that Mavi made and the highlights on where we are as a region in terms of HIV combination prevention interventions. In terms of what had been said, a lot of our HIV epidemic overlaps some of the things that Anton reported in Barbados as well. So we also have a mixed epidemic. It's generalized and concentrated. So in the general population, about 2% of the population are HIV positive. And we do have some studies that were done in collaboration with the CDC, including a BBSS study in 2015. And that information pointed to the fact that MSM prevalence was higher. It was about 19.6%. And we think that the prevalence of HIV would also be higher in other vulnerable groups like transgender women and sex workers, although we don't have that information in terms of a BBSS. In terms of the set of prevention interventions, we do have the complete set of prevention interventions that had been referenced, including HIV testing and counseling, STI diagnosis and treatment. Our most recent modality is PrEP that we have introduced since 2016. And we also have post-exposure prophylaxis after sexual exposure and the distribution of condoms and lubricants that are free. We are in the middle of Treat All. We've been implementing that since the end of 2016 as well. And I think it's an important part of what we do in terms of the consideration that HIV treatment is also prevention. And we are seeing with increasing the access to antiretroviral therapy and increasing the numbers of persons having viral suppression that we're having higher coverage rates, and definitely viral suppression is increasing too. Given the time frame, since I only have 5 minutes really, I can't focus on all of those interventions that we're currently doing, but I want to say that we have to keep in mind that HIV prevention has to be a combination prevention strategy, because there is no strategy that is 100% effective and efficacious. And so it's really important to keep in mind that it's clever to combine these interventions together. When we think about PrEP, we also have to think about condom use. I'm going to focus on a few of the things that have been effective in our setting. I'm going to start with HIV prevention and our partnerships with civil society organizations and key partners. I really think that this has to be underscored. When we think about the work that we do across the HIV response, we have to focus on partnerships. And the reason for this is because reach is different. So a clinician or a technical person may not have the same reach as a key population member. I had gone to one of our partners, SASH, the other day, and they shared with me that they have a large population of MSM who won't traditionally come into a healthcare sector and get tested. And so one of our interventions that was successful was work that we did in collaboration with PEPFAR, and that was the popular opinion leader intervention. So what we did is we identified leaders in these MSM populations, and they participated in a training exercise, a series of 10 sessions where we talked about all aspects of HIV prevention, condom and lubricant use, and there was respondent-driven sampling in that case. And so we were able to test quite a number of MSM, almost 100, and we found that the HIV positive rates that resulted from that activity were significantly higher than when we do outreach in the square or even provider-initiated testing and counseling. As a matter of fact, at the end of that activity, we found that the HIV positive yield was about 34.6%, as compared to something like community outreach, where we find that only about 1% of persons are positive. We've also been able to implement a more focused key population approach. So we have designated key population teams, including a clinician, nurses, peer counselors that will specifically work with MSM clients to build trust. We also had transgender support groups and work in the clubs, including the PLACE methodology. And that helped to test commercial sex workers. About 95 of those had been tested in one intervention in 2015, although the positive rates were 0% HIV positive. But all of these sex workers described in their behavior that they're using condoms with their clients. But we recognize that there are also gaps because they may not be using condoms with their partners per se. We also have other opportunities to do HIV prevention, and that includes various opportunities during the year, like regional testing day and community outreaches. I had some thoughts at the end of Mave's presentation, and I recognize that she highlighted that despite all the work being done with prevention interventions, there are still gaps, and the Caribbean region as a whole hasn't been able to see reductions in the number of new HIV infections. And I have some thoughts on HIV prevention for our region. So as we look at the 90-90-90 targets, it's important to consider that we have to prioritize prevention and focus on it as well. We have to keep in mind that we need to strategize. The way you reach a vulnerable population member will not be the same way you reach the general population, or even a serodiscordant couple or youth. And so we need to think hard about how we will have the most impact with those populations, including involving members of those populations and reaching people where they are. So in all aspects of HIV planning and strategies, we should engage these populations to hear from them how they would like to see their services offered. So similar to what Anton said, should you have a defined MSM clinic, some persons will feel comfortable going to a service that's offering tailored services. However, some populations may say that they prefer not to do that because having a standalone clinic on its own can also add to stigma and discrimination. We got a lot of that feedback from focus groups when we were doing our strategic planning. And so we recognize that the wants of these populations can be diverse and that we will have to be willing to adapt. So we've done some of that, including offering prevention HIV treatment at various times, including a clinic in the evening, and the willingness to work with partners to meet them at their facilities to offer care as well. We're going to need more commitments to end AIDS, including HIV prevention. Mave had mentioned in her presentation that a lot of donor funds are associated with the responses in various countries. The Bahamas too benefited from PEPFAR funds and linkages, and that has transitioned out of the region. There was a lot of support given to the prevention unit, and governments and countries will have to own their response to continue to sustain the work that's done. And we have to keep in mind too that prevention modalities will change as we move forward. So self-testing is one way that persons could get testing in a confidential, private way, but we do need to consider how we will link these persons to care and provide the support needed. And I also want us to focus on the fact that prevention, as we know it now, is not going to look the same as prevention will be years from now. There's going to be longer acting agents, injectables, microbicides, and other technologies that will allow for prevention. For example, the injectables, PrEP is an injectable. And we need to be open-minded and willing to consider how we can introduce these in our settings and be adaptable as well while we try and provide the support needed so that we can introduce these in the best possible way. So that's my 2 cents.
Thank you very much, Nikia. Thank you both, Anton and Nikia. Excellent comments. And we'll just move to the following section. Yeah, the next subsection within this comment section is actually addressing stigma and discrimination and other structural barriers. UNAIDS has recently launched a publication to help countries to address stigma and discrimination in the health sector. Considering this is an issue that has accompanied the HIV response since its inception, what does this publication add to support countries advancing towards reducing stigma and discrimination? And also, what would be some low-hanging fruits to address other structural barriers to HIV prevention services in the Caribbean? In this regard, we'll have Dr. Cedrian Martin. She is the communications advisor to the UNAIDS Caribbean sub-regional team based in Kingston, Jamaica. The team covers 16 countries and works closely with global, regional, and national partners towards ending the AIDS epidemic by 2030 as part of the Sustainable Development Goals. Cedrian is the team's focal point for human rights and community engagement. She was previously a journalist based in Trinidad and Tobago, covering issues including health, gender, and development. She holds a law degree from the University of the West Indies, Cave Hill, and a master's degree in communications from the University of Leicester. Okay, please, Cedrian, the floor is yours.
Thank you, Carlos, and thank you as well for the honorary doctorate. Okay. I graciously accept.
Yeah, I'm sure you get a lot of that.
So, thank you for the excellent presentation. And for me, there were 4 huge red flags for the Caribbean. First, that a third of our diagnoses are late. Second, that a third of our new infections are among young people aged 15 to 24. Third big red flag, we're having a slight improvement in terms of women and new infections, but an increase of 8% in new infections among men between 2010 and 2016. So we really need to focus on what's happening with men. And then the fourth red flag, of course, is that almost 2/3 of our new infections are among key populations and their partners. So I just want to start by reiterating Anton's point that we're not just talking here about key populations, important as they are, but we're also talking about what's happening with young people. We're also talking about what's happening with men and boys. And when we talk about combination prevention, we're not just focusing on the biomedical, we're not just focusing on the behavioral, we also need to emphasize the structural dimension. We need to look at decriminalization of transmission and of key populations. We need to address gender equity and gender violence. We need to ensure that there are protective laws, and we need to ensure that we have interventions to reduce stigma and discrimination. And as we come to the UNAIDS report on achieving zero discrimination in healthcare settings, that of course is ground zero for us if we want to improve our outcomes with respect to diagnosis and treatment. Because here we have countries doing this excellent work, providing services, but yet we're not getting optimal results. So what do we need to do to drive demand and get people to take, to access the services that are there for them? I wanted to talk quickly about a few studies that were done by the Health Policy Project and UE on healthcare discrimination in 4 countries in the Eastern Caribbean. And those countries were Dominica, St. Kitts and Nevis, and it was replicated in Antigua and Barbuda and Barbados. And overall, just looking generally at some of the results, we saw that 1 of every 5 healthcare workers reported observing a co-worker being unwilling to care for a patient living with HIV or providing poorer quality care to those patients. Also overall, just about 1 in 10 said they would prefer not to provide services to men who have sex with men and sex workers. So there's a very real issue. It's not imagined, there's a real issue about what people perceive when they come to clinics, when they come to hospitals, in terms of the attitudes of healthcare staff, and not just the doctors and nurses, but also ancillary staff. And so UNAIDS is suggesting 7 priorities in order to address this particular challenge. So I'll go through them slowly. Number one, to remove legal and policy barriers that promote discrimination in healthcare settings. Number two, to set standards for discrimination-free healthcare. Three, to build and share the evidence-based and best practices to eliminate discrimination in healthcare settings. Number four, empower clients and civil society to demand discrimination-free healthcare. Five, increase funding support for discrimination-free health workforce. Six, secure the leadership of professional healthcare associations to shape a discrimination-free health workforce. And finally, strengthen mechanisms and frameworks for monitoring, evaluation, and accountability for discrimination-free healthcare. And so if I could just briefly mention an example, in St. Kitts and Nevis, after this particular study, what they did was work together with their healthcare workers, have a training, almost 100% coverage in terms of uptake, and they developed a code of conduct with buy-in and inputs from the healthcare workers, and a system where patients are aware of their rights and patients could make complaints, but also healthcare workers have an opportunity to refresh their information and to be reminded of what the quality of care should be and what their duty should be in terms of standard of care to all patients coming into the healthcare setting. So there is a possibility for us to work together to address that particular challenge. But if you could indulge me a little bit, I thought it was important as well to talk about another UNAIDS report, the Blind Spot, which focuses on improving HIV services for men and boys. I'm not going to spend too long on this, but just to say that this is so important for the Caribbean when we see that the situation with men and boys is actually worsening over for the Caribbean as a whole. And so just three strategies that I'd like to emphasize: ensuring that we support a legal and policy environment that would facilitate men and boys accessing healthcare services. We know that we have to challenge those harmful gender norms. And, Anton in Barbados knows well, I know they designated men as a key population in the context of their epidemic. We need to engage men in terms of improving their health-seeking behavior. And make it consistent, make it a strategy so that we ensure that we're capturing them. And then finally, ensuring that our services address the common barriers that men face and accommodate the diverse needs and realities of men and boys. And I would echo Nikia's point that it's not necessarily that we always need standalone facilities in order to serve our key populations. Some members of our key populations don't identify as such, and it would be more constructive for the region as a whole if we really do a better job at attending to what's happening with half of our population, ensuring that they feel included and they are catered to when they access their treatment and other health services, not just HIV. On the second point, which is about what's the low-hanging fruit, what can we do? There are so many civil society organizations in the region that have the capacity to connect with those hard-to-reach populations. And we're talking here, of course, about the gay, bisexual, and other men who have sex with men. We're talking about the transgender women, sex workers, and so on. They have the skills, they have the know-how, they have the networks. And I think as a strategy, if we can get the funding to them, if we can enter into social contracts that would allow them to do what they do best, they could really help us to fill that gap and reach our targets in terms of prevention and also in terms of treatment, so that we have the healthcare system covering one set of people, but those that are the hardest to reach, we ensure that we have our civil society organizations helping us to fill that gap. So I'll stop here for now. Carlos, are you?
Yes,
okay.
I'm here. I was just I'm turning on my mic. So great, thank you very much. Very interesting comment, Cedrian. Thanks a lot. So we'll move to the final comment here. The final comment is from a perspective of civil society. So it's I mean, the introduction is as follows: the PAHO UNAIDS, PAHO UNAIDS publication has highlighted the importance of civil society for the response and its key role addressing key populations. At the same time, it raises concerns with regard to its fragile sustainability. Could you address this apparent conundrum? Could you also share with us alternatives to address the sustainability of the HIV response in the Caribbean? For example, with regard to social contracting. So this is going to be addressed by Rachel Erst. And let me just briefly introduce Rachel to the group. Okay. Rachel is a public health physician and has worked in a variety of technical roles in Suriname and in the region. She has worked, amongst others, for PAHO as public health advisor on HIV STIs for the government of Suriname, as a clinician and as the head of the preventive health department for the government of St. Martin. And since 2016, she is the program officer of the Linkages project in Suriname. So please, Rachel, the floor is yours this time.
Yes, thank you, and good morning, everyone. Yes, and thank you for this nice picture. I have to tell you that this is an old picture from more than 10 years ago. So I'm also part of going into the way of obesity. So I look a little bit different, but thank you for putting that picture there. So I have to talk about the civil society perspective, and and I'm going to do it a bit from my role as a program manager of the Linkages project here in Suriname, because I am not part of the civil society, but I work very closely with the civil society. I have heard from all of our previous presenters, and thank you very much for your comments and the presentation, that we have to acknowledge the work that the civil society is doing. I've heard from our colleague from UNAIDS that is the civil society who can connect with the key population. We have to fund them, social contracting, they can fill the gap. We have also heard from our colleagues from the Bahamas and Barbados that the civil society, they play an important role. But we also know that the HIV prevention is mainly financed by external funding. So our countries are depending on external funding, and especially the funding for HIV prevention, the combination prevention, for the key populations. We know that the donors are transitioning out of our region, so we should look at alternatives. And I think that it should be, if we look at alternatives, it should be on combined efforts. It's not only the civil society who should do certain things, but also the government, but also the donors, to my opinion. And what I think that the government should do, and I think that our colleague from Bahamas had mentioned it, there is political will, but the government should own the response. But the government should also understand the cost and the benefits of the civil society engagement in the national response. Sometimes they are like, they are civil society, what can they do? But to understand the cost benefits of the civil society engagement in the response, we need to have accurate information in the expenditures. We don't have a very up-to-date national health account, and I know that different UN agencies and donors in the region are working towards an accurate national health account. But we can only have an accurate information on the expenditures when we have defined what the package of services will be. In this WHO, PAHO has defined a whole package of services that we should give to the key population. And I believe that this complete package of services should not be like a vertical approach, but it should fit into a broader model of care. This model of care should be holistic, it should be client-centered. But if we have the complete package of services, if you know what we put into that, and I know that in Barbados they're working on a package of services for the key populations, we also needed to know what is the coverage of our services. In some countries, we know we have accurate information on the sizes of the key populations, but not in all countries. So we need to have that information, to have accurate information on the expenditures. If you have that information, then the government, when the donors will phase out, they will need to make a decision to increase the domestic resources for HIV prevention. And they also need to make a decision on how to reallocate that to the key populations. They also need to think about task shifting model. Some tasks that are now at the health sector, at the government, in the public health centers, they can be shifted down to the community, to the CSOs. They are already doing some services, but we also have to look then at the legal restrictions of task shifting to the civil society, because maybe some tasks can only be done by nurses or by doctors. And based on the package of services, we should also look at the standards of care. I think that the government need to play a role in that. If you're saying, okay, the outreach services, the outreach will be outsourced to the civil society through social contracting, you need to define that, okay, what will this outreach package consist of? Or navigation support, what will this entail of? What are the standards of care? And how will you monitor that? They also needed to have a kind of a transparent process of selection of the civil society as service providers. On the other hand, the civil society, also what I see, and then I'm going to talk about Suriname. We had a meeting with the civil society organizations, and we had discussion on social contracting, and it became very clear that the civil society organizations, they needed to work together, they need to have one voice. They needed to have discussion on what are the comparative advantages of one organization next to the other organization. What are the strengths? What are the services? And they should have then one voice to bring that across. Oh, this organization, this is their expertise, and this is the other expertise. So they should not compete for these services. And civil society organizations also should look at different financing mechanisms. Yes, we have the social contracting, but then you need to have well-defined projects for good quality. You need to have your systems in place, not only your financing systems, but also your quality care system. So there is some work to do there. But the civil society, when they're looking at sustainability, they also should look at different financing mechanisms, the social entrepreneurship, the private sector engagement. There are a lot of private businesses, they have a corporate social responsibility, so they should scope for these private businesses and see if they fit their profile to create a kind of a win-win situation that they can fund certain parts of their services. So civil society themselves, they also have some work to do when we are looking in the era of without donors. So they have to look also at sustainability. The third part is the donors is also an important stakeholders in this whole sustainability. When you're looking at sustainability, They know that they are transitioning out, and I know that most of the donors they have in the last year, they provide support for transition. But the transition should be focused on providing technical assistance for the government, how to do that. And I know that there's a lot of activities is going on this. There is an especially for Global Fund, there is counties are asked to make a transition work plan. There are sustainability task force set up in different countries. But also, I believe in this transitional phase, there should also be institutional capacity strengthening for the civil society. And with this, I mean, it should not be only focused on strengthening the technical intervention, because that is usually the case. We're looking at, oh, how can we do PrEP? How can we do this? How can we do that? But also looking at how can they be partners in the whole chain of providing services. So looking at the financing system, quality system, how should they define and sell their products? And I know that one organization, I think FTI, the Local Capacity for Local Solution Project, is at this moment in the region looking to see what kind of support they can provide to a civil society to go into the direction of social contracting. So to summarize, civil society, we have seen that the work is of importance. They can reach the key populations. We're going into the era of without donors, so we have to look at sustainabilities, but government has to play the role. The civil society has to have some work to do, but also the donors. I will leave it by this. Thank you.
Thank you very much, Rachel. So we've had 4 very nice, very interesting comments on Maeve's presentation. And I mean, given that it's already slightly past 10, I think we can't go into questions, but we can ask Maeve to provide a final comment based on the comments received to her presentation. So Maeve, would you be willing to do that, please?
Well, thanks, Carlos. Considering the time, I really want to acknowledge and thank the availability of all of you to be here with us. And I think the comments did complement in a very nice way, the results and the way forward that the documentation that we publish in the report. So it's really to thank you all, and thank you, Carlos, for this opportunity, and make ourselves available to answer questions by email in case you have received some. Yes,
thank you very much, Maeve. I think this has been a very, an excellent session, because the presentation, was also, short sometimes. There was so much to present, but remember, in the invitation you had the icon of a report. So there's a link there, and that report should be widely known in the region, in Latin America and the Caribbean, well distributed, and people should be able to consult it, to look at it. So in terms of comments or questions, we'll post Maeve's email address, and the other participants, the commenters' email addresses as well. In the event people have questions, we're going to actually upload the recorded session soon in our YouTube channel, and also in our website, so people can access it if they want. So definitely the idea is that's the other thing that came up in the discussion in Spanish with Latin, Spanish and Portuguese speaking countries, that definitely we need spaces to keep discussing policy, because this is not the time to continue to just do business as usual. This is the time to really reflect on what we're doing, to see if we can start doing more, no, or better, to stop doing things that perhaps are not relevant any longer, and to incorporate things that, from a combination prevention perspective, would be of benefit to our countries. So again, thanks a lot for your presence here today, and especially thanks very much to Maeve for presenting, and to Anton, Nikia, Cedrian, and Rachel for their excellent comments to the presentation. So thanks a lot. And you know, this session has been recorded. You will be able to access it very soon. And we'll keep in touch about the next webinars in Spanish and in English. We'll schedule here at NEMUS. Thank you again. Bye-bye.
Thank you. Bye-bye.
Bye.
Bye. Bye-bye.
Bye.